Coming to the last case, this is a baby born at 35 weeks, 2.2 kilos, small for gestational age. It's a gravida 2, para 1 mother. The father is a second degree consanguinity, second cousin. The first baby is healthy. The baby was born by emergency cesarean section for breech, did not have to come to the NICU. Baby had sugar monitoring because of the mother having diabetes in pregnancy, no other antenatal concerns. The scans were normal in pregnancy as well. During the initial admission, the blood glucose monitoring was normal. The baby had feeding support and was clinically stable and discharged home like a normal baby by day 3. However, the baby presented to the emergency on day 5. Baby was due to have the post-discharge visit in the same evening. We had noticed acute blueness with breathing difficulty that afternoon after a feed. The saturation was 70% in room air at the ER review. The baby was started on mask CPAP and oxygen. Saturation improved. Baby was shifted to the NICU on high flow nasal cannula, and the blood gas was reasonable. pH 7.37 and CO2 48. The blood count, CRP, renal and liver functions were normal. The viral screen was negative and the blood culture was negative as well. So again, we gave ampicillin gentamicin at admission, but stopped it after 2 days as the CRP was thrice normal. The pediatric cardiology done echo showed severe PPHN at admission. The TR, the pulmonary pressure, there was tricuspid regurgitation and the pulmonary pressure was suprasystemic at 67, and there was a right to left shunt through the PFO. Clinically, at that stage, we thought whether the baby had an aspiration pneumonia at home, and obviously, being an IUGR baby with high risk of PPHN, the baby could have gone into the persistent fetal circulation physiology, the hypoxia provoked by the aspiration. The baby was clinically stable on the non-invasive ventilation, but continued to need 30 to 40% oxygen, had persistent subcostal recession, so high flow could not be weaned. So this was the chest X-ray, and at that time, it seemed consistent with the picture we had seen clinically. The repeat echo the day after the admission showed improving PPHN picture. Obviously, the hypoxia had corrected and the PPHN started improving. The baby was kept on OG feeds. Where our practice is to keep the baby on full OG feeds if they are stable on non-invasive ventilation, but we don't offer suck feeds till they are off the respiratory support. The baby had a TSH of 29 on the newborn screen, and we repeated at that stage it was normal. The chest X-ray was repeated after 5 days because the baby wasn't improving as we would expect. And here we could see more fibrosis pattern, or the streakiness was very clear. So we wondered whether we are dealing with interstitial lung disease. And the baby was started on nebulized budesonide as a trial, just thinking whether the lung inflammation related to aspiration pneumonia. And we thought we will give it a trial for a couple of days and then do a chest CT to rule out interstitial lung disease at that stage. So the chest CT was done after counseling the parents. So this clearly shows the thickened interstitium, bilateral and almost homogeneous. So it was there in multiple cuts as well. So bilateral diffuse thickening of the pulmonary interstitial septation, picture consistent of diffuse interstitial disease. So they suggested lung biopsy. We referred the baby to a center with pediatric pulmonologist. The baby continues to be on high flow, and they considered congenital interstitial glycogenosis as a most likely diagnosis. They started pulse steroid and hydroxychloroquine. Initially, there was a response, but then it started stabilizing at the same level. They sent genetic workup, and I think the family flew to Germany for further management. I'm not updated on the last picture. So this is a good review, and I'm sure you'll find many good reviews on this topic as well as updates. Interstitial lung disease is a group of disorders which involves both the air spaces and the lung interstitium, and results in diffuse lung disease. It's very rare, but it's associated with significant morbidity and mortality, and the prognosis is quite variable. Some of these conditions may result in fatality in the labor room, while some may survive with the long-term support. And the lung histopathology is a gold standard, but we have significant progress in genetic diagnosis, so we may be able to diagnose more and more of these conditions by genetic testing. So the characteristic clinical and imaging features may allow the specific diagnosis. We have the grouping of these conditions into subcategories. So the developmental disorders are the ones that present fairly early, and I will mention that next. We have growth disorders, which could be either congenital or related to prematurity and related factors like BPD, where the lung growth is disturbed. We have the surfactant dysfunction disorders. Again, they could present acutely with surfactant apoprotein B deficiency or RDS, which doesn't respond to your typical management. And there are specific conditions of unknown etiology, which are unique, like the interstitial glycogenosis we mentioned as well. So the prevalence, it varies a lot depending on whether you're including the severe cases or the mild cases as well. So 0.13 to 16 cases per 100,000. The developmental disorders, the most severe is acinar dysplasia. So I had one case of acinar dysplasia where we went for resuscitation. The baby cried immediately after birth, but then there was zero oxygenation, and we did a postnatal MRI, postmortem MRI. We couldn't save the baby because there was no oxygenation happening, and the postmortem MRI was consistent with lung hypoplasia, poor development. There was hardly any aeration, and then the biopsy confirmed acinar dysplasia. So the baby has a normal neurology and the reflexes are normal, so the baby cries. This is a scary situation to both the obstetric and pediatric teams because you wonder what went wrong subsequently. And these children are difficult to support because this is not compatible with oxygenation. We have congenital alveolar dysplasia, which is also a developmental problem. There is an arrest of lung development in the alveolar stage, late canalicular to saccular phase. And these infants also have severe lung disease. And as with any severe lung problem, pulmonary hypertension is present. They can be supported in the diagnosis established by biopsy, but most of these babies succumb later on unless you do a lung transplantation. The alveolar capillary dysplasia with misalignment of the pulmonary veins is a larger category as well, and these babies present with severe hypoxemic respiratory failure and pulmonary hypertension present shortly after birth. They're quite difficult to manage and usually leads to death in the neonatal period. So the typical pattern of this is the lung biopsy findings, and there is a genetic background to it, the FOXF1 gene linked to the pulmonary vascular development as well. You always consider this in a very refractory PPHN where baby doesn't respond to the treatment. So in typical cases, you have a thickened interstitium, poorly developed capillary bed, the lobulation is abnormal, and the pulmonary veins run in the same bronchovascular bundle as the pulmonary artery. So that's why we call it the misaligned veins, alveolar dysplasia with misaligned veins. In the normal situation, the pulmonary vein runs in the intersegmental septa, while the pulmonary artery runs alongside the bronchi. So it's a different situation. The alveolar growth disorders, mainly BPD, where there is cystic changes in the lung as well, CCAM or CPAM are also in this group of conditions. And we have the surfactant disorders where the baby presents a severe RDS, surfactant apoprotein B deficiency is well known and it's inherited as well. And we have congenital alveolar proteinosis where there is alveolar membrane leaking and similar to the surfactant protein B deficiency in presentation and severity. We have the neuroendocrine cell hyperplasia of infancy. We discussed the primary ciliary dyskinesia as a cause of persistent TTN. This also could lead to persistent TTN-like symptoms. And the index case we are discussing, pulmonary interstitial glycogenosis. The biopsy findings include interstitium widened by immature mesenchymal cells, which contain glycogen. So you can do a PAS staining on electron or do on electron microscopy. And there is relatively little inflammation in the lungs in these cases. So both these cases tend to improve with time, and you have some response to steroids or immunomodulating treatment. And of course, primary ciliary dyskinesia itself could present with interstitial lung disease pattern. The case was discussed earlier as well. So to conclude, interstitial lung disease is rare and it's challenging to manage. The prognosis is often unpredictable and poor, and we have to be careful with counseling of the parents. We should not give them hope more than what is possible. And obviously, some cases may not even go past the NICU stage. So it depends on the severity and luck, and obviously the family pattern may help you predict. So to summarize, we have discussed 3 different cases, varied pathologies, and we have to be alert to atypical cases and how to approach them. We are not experts in the field, and the pulmonologists and the respiratory experts are going to be the experts in the field. We do need significant input from genetics as well. And I think